How did you know the bacteria somehow involved in the correlate to the stem cell?
Okay, that's I have to show something interesting. Let me show. Yeah, I have to show the first one. I have to show this one. This is the final. Okay. We are the first one to show. Actually, this is the final. That, okay. These are the mesenchymal stem cells, CD271 positive bone marrow mesenchymal stem cells. We recover from patients also. Inside them, there are bacteria, the Mycobacterium tuberculosis. We published this in Science Social Medicine, a huge data. At the time, what we found was very surprisingly that stem cells are so sensitive. It's almost impossible to think of how bacteria can colonize intracellular compartment of stem cell, because stem cell doesn't have all this compartment like the lysosome that the macrophage has. So we're very surprised that we can isolate bacteria from the stem cell. So after we published this work, and we took about 6 years to publish, to show many data from patients, mouse model, in vitro, because it was unheard of that bacteria can survive inside stem cell, and stem cell can remain quiescent, right? So what we found was that this bacteria remain very quiescent, they remain very dormant. They exploit the stem cell needs to maintain dormancy for years. Because TB is a disease of dormancy. TB remains dormant for years and years, then it reactivates. And interestingly, in this paper we showed that we could not find this dormant bacteria in the lung of a mouse model of the TB. We only found in bone marrow mesenchymal stem cells. After this finding was shown, then there's a huge explosion of the field, that microbiome stem cells, that we can actually isolate all kind of bacteria from stem cell, from also cancer cell. We still don't know though how this bacteria survive inside the stem cells. There are theory, and our finding shows that bacteria manipulate the stem cells, the stemness program. The stem cells remain quiescent. And this is what we found. We showed in this, if you have time, please read this paper. Here. This is a robust model here. You can, this is a mouse model of the TB dormancy. What we do is we infect these mice with a MTB strain of 18B. Interestingly, 18B strain was developed in Japan back in 1920 to 40. 18B, a oxystrophic bacterial strain. You need streptomycin to reactivate the strain. Without streptomycin, the bacteria would not grow. So when you first infect the mice with this bacteria, 18B strain, we have to treat the mice with streptomycin. The mice will develop the TB over the lung everywhere. Once you stop giving the streptomycin, bacteria disappear. Mice become healthy. For years, it was considered that this bacteria completely disappeared from the lung, because everybody was looking at the model, looking at the lung to look for the dormant bacteria. They could not find it. So it was considered that 18B model is a good model for not dormancy, because we could not find the dormant bacteria after stopping the streptomycin. We are the first to show that you can recover this dormant bacteria from the mesenchymal stem cell in lung, also in bone marrow. That work we published in the year 2013 in our science paper. Here we use that model, a very strong model of mouse model of dormant bacteria inside mesenchymal stem cell. And there, when we did a molecular study, it is not shown, this mesenchymal stem cell, they have a program where they activate nano-SOX4. They almost have an embryonic stemness kind of profile, but they do not activate the VEGF receptor 1 or CXCR4. because VEGF receptor 1 is only activated when these cells activate altruism. When they remain quiescent, they do not. So it seems that bacteria, when they want to tweak the stem cell to become altruistic, they somehow manipulate VEGF MAP kinase pathway. That the VEGF either RAS or other way, like this, the pathway we found first, we're still here. Yeah. Yeah. This one we have only downstream from phosphoheave, FLT1, we found ARC1, 2 and MAP kinase. This pathways, we're still working on that. We found that bacteria can somehow manipulate this pathway. We still don't know how they do it, where they do it. We still don't know that. But once they manipulate this pathway, this cell become altruistic stem cell. So to answer the question, there is a crosstalk between bacteria and the stem cell molecular pathway. And thankfully, we have a good model to study. We have been, establishing this model.
You mean you are working with the human cell from the patient,
Yes.
also the mouse model.
Yes.
And in your case, both the human stem cell and the mouse stem cell both contain the bacteria.
Yes.
Oh.
So what we do is we take the primary tumor cell, we lyse the cell, we have the hood here to culture the bacteria. We take the cells, lyse them. If you want to see, why don't you show some bacteria? Do you want to see some bacteria right here?
Once after the tea,
Huh?
we can
Yeah.
show them. After the
Yeah. We'll show you right here. Yeah.
Yes.
Yeah, we do that. And there's the advantage of doing here work in India because I am a physician. These are all my patients, right? Back in Boston, I could not do that.
The sample, yes.
I have my samples. That's the biggest advantage I have. And we know when I look at the patient, because I have big Saturday follow up with patient, we know, okay, this patient might have bacteria now in the cancer cell because their CRP, the clinical things come up. They develop septicemia. So easy to bring the sample, qualify process here, isolate the bacteria.
In the samples from patients,
Yeah.
so how many among the patients you collected, how many percentage showing the morphology of the altruistic cancer samples?
Oh, not many. I mean, this is again, I think out of we have selected about out of 35 selection, we found into 21 patients, and from 21 only we found very, very good data. I think patients, six patients, yes. This is our, after doing many years of work, because these are very rare cells, circulating cells, Most of the time when I can bring them, they do not grow. So we have developed a special media, a knife mesenchymal stem cell media. We grow them, then we can expand these cells. But we're submitting grant now, so we can do in a large scale population to have bigger effect of the study.
Yeah, because as you mentioned that I thought also because the population of this cell might be very small and very difficult to find.
Yes.
So if you how to find the specific group of patients and that have this population, and then also if we can, because if you can find this, but the strategy would be that if you can find this population, you can target it, and then it can be a treatment.
Yes. That is one of our ongoing projects where we want to identify biomarkers for patients who have altruistic stem cells. That is one of our ongoing projects. We are yet to do that. because since the population is so less, when you take the blood or something, the amount of protein which are unique or novel, their population is also very less. So, but still the thing is ongoing right now.
So this is our lab there. We have a biosensor lab. Our ultimate goal is to have a biosensor microfluidic device. So that we can get little cells. This is where Lekhika will be working.
But also here also when we have collected the samples, because he has his clinical expertise, so our selection criteria was very specific to those patients where clinically also we have observed that after cisplatin therapy, they have actually, their tumor got exploded. It should reduce right most of the time, but it did not. So then we have collected for those patients where we found this result, we have selected the patients who are under cisplatin therapy, who is in stage 3B or stage 4. So where surgery is not possible, or initially when the surgery was done, we collected a tumor tissue sample, and then when they were under cisplatin therapy, it's during the first to third cycle of cisplatin therapy, we collected the sample. So in those samples or in those group of patients only we observed that. So it has also clinical relevance. So though the sample number is less, but we could relate the result with the clinical significance. But because the number is less, so the clinical result, like the follow-up of the patient monitoring, we did not report in this paper. But otherwise, it's relatable.
Yeah, I use this for my diagnostic purpose. And also you can see our slide here. What we do is most of the time we collect the blood, 5 ml blood for the PBMC. They do the fecal separation quickly here. We stain with GMC or white GMC. Look for the cells. We find atypical cells. We have some slides, right? Why don't you show the markers afterwards? Once you find those atypical cells, and I get an idea, because I have been doing this for many years. PBMC, I'm collecting since 2002. So looking at the patients, looking at the PBMC, you can have a feeling, okay, this patient left circulating tumor cell. Mostly we find them after chemotherapy. Because after chemotherapy exposure, these cancers, they kind of activate this altruistic mechanism for their survival. Probably. That's how the patient selection, as Lekhika says, is very important. If you know how to select, then you find it. Otherwise, it's like looking for a needle in a haystack, Yeah.
So it is actually helping us in decision making of the patient treatment suggestion when he is an oncologist or we as a team from KTC that we have visited yesterday. So when we provide treatment suggestion to the patient or their specific oncologist, we used to observe this data in the lab. Based on that, it helps us to take the decision that no, we should not continue with this cisplatin anymore. It might more enhance the tumor growth. But since we really need a lot of good, better data and in larger population to convince the doctor or the current group of people.
Yeah, this is the public. Cisplatin treatment increases survival and expansion of a highly tumorigenic site population fraction by producing VEGF-1 autocrine signaling. This is where Masabumi was very excited because we for the first time showed that cisplatin treatment, even though we treat this patient to reduce cancer, they can activate this autocrine signaling, enhance the fitness of this cancer cell. So we can now select this patient. If I know that they have this increase of these cells, I stop giving them cisplatin.
So that's how it is helping
It's
us.
helping for clinical decision making. I hope that as we expand our field, because now only after 20 years of finding molecular mechanism, we can do a large-scale trial to, maybe take 1,000 patients and make this our experience become a medical oncology protocol to look for patients where cisplatin will work or would not work. So far it's a dilemma, but about in head and neck cancer patient, 60% patients cisplatin work wonderfully. 40% doesn't work. We cannot figure out 60 and 40. So hoping that this our knowledge of stem cell altruism will help in the selection criteria. From whom should we give with cisplatin, whom we should not.
Those 6 and 4 are in what stage?
60-40 means those in stage 3 and 4, head and neck cancer. The gold standard treatment is cisplatin monotherapy. And cisplatin is very affordable, very cheap. An Indian patient, because I always with rural patients. You have visited yesterday village, right? Very poor people. You cannot give them immunotherapy, targeted therapy. So cisplatin is the best choice for them. So if you can select those we can add 60% of them, it's so good. But now that we do not know, the medical oncologists don't prescribe cisplatin. Even for poor people, they'll prescribe expensive drug.
Immunotherapy, but they cannot
Right.
go with the
So you want to re-establish the cisplatin therapy. It's affordable. Similarly, BCG, that has shown that bacteria can target cancer stem cell. BCG is a very cheap immunotherapy, very affordable. If we can organize ourselves that, okay, these are the patients where BCG will be benefiting, then we can have an affordable immunotherapy.
Question. So the patients are just here in Guwahati.
Yeah.
In this paper.
Yeah.
So all the samplings are.
Yes,
Yeah.
I mean, like in the cancer patient population is from mainly Swalpusi.
Do you have an app here? App? Where to show the app? We have an app.
But the TB patient population is also from the mesenchymal stem cell report,
Yes.
science translational medicine. That is from northeastern population. So
Yeah.
yeah.
The TB population come from Arunachal Pradesh. It's a province here. Also from Assam as well.
And like, how often? So you do it this regularly? Like,
Well, I mean, this area northeast, our Assam, is one of the world's highest incidence of oral cancer. Head and neck cancer is the highest. We have about 300 cancer patients. And if you say app, we have a digital app. We just follow them.
It is a control.
Yeah.
Let me try.
But this is why I was insisting to Harvard that I need to keep this lab or the clinic. Because in Boston or Massachusetts, Mass General Hospital, it's so difficult to recruit patients. We cannot do that.
But it's not limited like for like rural agriculture only. Like University of Tsukuba has a medical faculty of medicine.
Yeah.
And what I think, like those that specialize in stem cell could visit here, look what are the initiatives being done here.
Oh yes.
Yeah. I think I would recognize Onadai. He was in Toronto. I saw his face yesterday. I recall. Because he was with Sudai, or I met him in a conference. I used to go to Keystone Conference. It'd be nice to have him here.
He was here last week.
Here?
Yeah.
Really?
In Guwahati.
Oh my God. Okay, I think so. Okay.
Yes, he was very busy.
Yeah.
I
tried
see.
to bring him, but
I see.
he was having all the
Okay.
appointments with Chief
And I
Minister
think he will be
everybody.
back in
Ah.
November.
Who's
I
coming back?
Because we will have a campus in campus meeting.
Oh, okay.
Yeah. Because he worked with Toshio Suda. And Toshio Suda I worked before.
Who else is doing stem cell in Tsukuba?
There is one. Actually, she want to join, but she can't do that. I think. She also work with stem cell and MRSA. So my one of my colleague evaluate the adipose tissue MSC
Yeah.
antibacterial effect into the MRSA.
By the way, we have a mesenchymal stem cell that we're under review now. We are doing this in a CGMP facility for therapy. Our first publication of mesenchymal stem cell was in 2008. And then we focus on mainly bone marrow. We also have adipose tissue one, and then we got back to this umbilical cord. But one key problem with mesenchymal stem cell field is this always. we still don't know whether they're stem cells or stromal cells. Because as you grow them in vitro in a culture, in our field it's considered that some of them become stromal cells.
Yes.
So that's we have developed a naive culture media. Culturing mesenchymal stem cell and hematopoietic stem cell media. That's how. This is all detailed in our science translational paper. Because when you want to culture this TB-infected mesenchymal stem cell, it all failed if you use this high culture media.
They already differentiate.
They already differentiate. They could not take the bacteria. The bacteria would not survive inside the stem cell. But that's why we use the hematopoietic stem cell media.
Professor, are you not considering to use the IPS?
IPS I worked before. I worked IPS briefly at Stanford University with Dr. Joe. I forgot the last name. He was the IPS guy. And at first, when IPS Yamaka came, it was 2005. He came to Toronto because Toronto is a hub of stem cell research. In fact, stem cell was discovered in Toronto, in my hospital where I worked. And my project did not really go through because I was always focusing on physiological stem cell. I'm a doctor, my thing is this pathology, physiology inside our body. I did not have any interest in this regenerative medicine per se. I wanted to know whether the stem cell altruism mechanisms exist. If so, if the bacterial cancer is manipulated. But at Stanford, I was told I should use IPS as a model to study stem cell altruism. I still have some unfinished work, but we have preliminary finding that when you generate IPS, there's still a black box. Only 20% cells eventually become IPS. Because once after transfecting any fibroblast, 3 weeks, 4 weeks follow-up, many colony die. Only few survive. They're clonally selected. And now we know that they maintain tissue memory. Even though we say IPS, they're not really induced pluripotent stem cells. They do have tissue memory, epigenetic memory prevail, right? So during the genesis process, how this cell fibroblast reprogram eventually to IPS, we still don't know. We know it's reprogramming, we still do not know a detailed molecular mechanism. And I think somehow there is some other cells that sacrifice their fitness probably for IPS generation. I developed a project, I got a little funding on Stanford, but when I moved to Forsyth, Harvard, I have to really focus in my lab on this cancer and TB work and IPSs. I could not recruit a student so far. And when I moved here in India, even though in IIT, but we are actually a small lab, we're independent, non-profit, because I have to keep it non-profit independent. If I become a part of IIT, I cannot have my Boston lab, So having a small lab is difficult for funding, and so that's why. If I get funding, Japanese collaboration will drive the IPS. Because I got training in IPS back in 2004. Iwanaka himself with, what they call Zans to Toronto, he trained us. So I have some picture, old picture. At that time, he was a normal guy. Nobody believed in him. So that time he came. Yeah.
So here, sir, because of the internet connection, not being able to show the live app,
Yeah.
but we have a video of our app, so I can just probably show them.
Yeah.
So this is our patient app. Like yesterday you visited, so it's called KaviKrishna Healer app. Here are all the patient registration, total patient 350. This is still we have to because we have just developed this or launched this app last year. It's not, it's still a pilot project as an app. So we have a patient since, organized since 2018, but we still have a lot of patient data we need to incorporate. And we have to be, following the guidelines too in healthcare project. So here we collect all the data, and our clinical coordinators yesterday, there are 3 beautiful girls who were showing around. So they are the patient coordinator taking care of the patient along with him. And from here we coordinate with them, collect the samples. So here the doctor, patient coordinator and the patient, they can talk at any time they have the questions. So this is the way we are taking care of the patient, also trying to bridge the gap between the research and the clinic. So this is the app, just wanted to show. Like you asked the question, right? So the patient population. So our main area of patient population is this Valkusi has one area.
Yeah.
But now it is slowly increasing because people are knowing it and coming to us.
Well, I have been doing clinical practice in that area, my area, since 1994. So this is a population of 150,000 people. We know them, they know us. I'm like a community doctor for them. So it's easy for me to convince them and work with them. Also do a long-term follow-up. I mean, for us, we can do a very good stem cell study, mainly for physiological, pathological role of stem cells, more than technological things. As you know, mesenchymal stem cell, we still don't know what is the role of mesenchymal stem cell in our body, in regeneration. We don't have good clinical data. So that could be, we have a good translational opportunity.
Yeah, we have recorded the use of the app so that we can show it now. I'm trying to open it because it has 3 login details from doctor's side, patient coordinator and patient.
If something gets stuck.
And also just keeping the video record, screen recording of the use of the video.
Eventually we want to have a digital AI app so that, because I have been giving treatment for 3 decades, so I have my own style of treatment. So I should be Bikul's avatar, because me and,
So this
AI
app
would
is-
be Bikul and get the treatment.
So the AI is like, all the information are recorded in the app, then AI will create.
Even my voice, the way I talk to patient, everything could be simulated now. We have 3 decades of data, video or audio. But be good digital lab, mainly for community oncology care.